This is an ABC podcast.
Hello and welcome to this week's Health Report with me, Norman Swan. Today, a preventable epidemic in Northern Australia leading to babies dying. The economic and personal burden of neurological, mental health and substance use disorders in Australia. How we need a universal dental care system in Australia. And for years we've heard about the benefits of incidental activity. A walk to the shops, taking the stairs. But what if you could transfer the principles of high-intensity interval training, those are short spurts of intense exercise that get the blood pumping, to this incidental movement we do every day? Researchers are suggesting you can pack a workout into just a couple of minutes a week. Heaven. Health reporter James Bullen has the story.
Level 4, going up.
It's 8:33am. I've just arrived at work and I'm taking the elevator up to Radio National. This is part of my daily routine, but I've noticed some colleagues have a more peculiar and punishing route to level 4. Rather than the lift, they trudge up 8 flights of stairs, then another 8 to get down for lunch, another 8 after lunch, and another 8 to leave the building. They do get a bit of a huff and a puff on, but how much good does it really do?
Incidental physical activity is whatever we do for day-to-day living that is not done specifically for the purpose of exercise, fun, or health.
Emmanuel Stamatakis is Professor of Physical Activity, Lifestyle and Population Health at the University of Sydney.
So incidental physical activity is, we walked from the lift to my office, you walking to the bus stop or the train stop. If you had to carry your heavy shopping from the supermarket to the boot of your car,
You might get all the exercise you need playing sport or going to the gym. But if you haven't exercised in a long time, if you're overweight or obese, or if you're very time poor, these exercise snacks could be appealing.
this is the beauty of it. Zero time commitment. It is not necessary to make the time to walk up the stairs instead of the lift. The chances are that you could have walked up the stairs quicker when you came to see me.
And we've heard about the benefits of incidental activity before. The catch here is that you can't just go for an ordinary stroll in the park. Researchers would usually categorise that as moderate physical activity. But high-intensity incidental activity, like sets of stair climbs, is tougher.
Vigorous physical activity, vigorous aerobic physical activity, is when you get to a point you're so much out of breath that you find it hard to speak, or you can only speak in short phrases. On the other hand, moderate intense physical activity, you should be getting slightly out of breath. You can talk, but you cannot sing.
Professor Stamatakis is the author of an editorial in the British Journal of Sports Medicine talking about the potential benefits of this type of exercise.
The evidence is very encouraging. It's small in volume, very small in volume. There's an opportunity here for us researchers to shift our physical activity paradigm here and stop thinking about amounts only. Amounts of physical activity are important. There is no question about that. But it looks like that it is not only about the total amount of physical activity. The quality of physical activity, in particular the regular sessions of high-intensity physical activity, no matter how brief they are, they seem to be very, very promising.
In one small Canadian trial, researchers saw an improvement in the cardiorespiratory fitness of a group who performed sets of stair climbs after just 6 weeks, compared to a control group of people who did nothing at all.
The evidence from these trials is very, very encouraging because we can see that among groups of very young adults between 19 and 22, 6 weeks of a protocol of stair climbing that consists of 3 climbs per day, 4 hours apart, and every climb is only 3 flights of stairs. Every climb is 20 to 22 seconds. Total daily dose, 1 minute of exercise per day, 3 days per week, over 6 weeks, we can see measurable increases in cardiorespiratory fitness. Now, if we were to repeat this kind of trial in a sample of middle-aged, sedentary, or older adults, unfit people, basically, who have been exposed to a sedentary lifestyle and physical inactivity for decades and decades, I expect we would see a lot more dramatic results.
And higher levels of cardiovascular fitness are associated with lower risk of heart disease, type 2 diabetes, and stroke. Professor Stamatakis emphasises this field of research is still very young. But if high-intensity incidental activity works, how much do you need?
The majority of the population, especially if we consider the middle-aged and older population, they're very physically inactive. They are typically people who don't even do half an hour or 20 minutes of moderate intensity activity every day. They do much less. For those people, who I will emphasize once more, is the majority in our population, 3 or 4 sessions of high-intensity incidental physical activity, even if it's as short as 20, 30, 60 seconds, 3 to 4 times per day, I am confident can have dramatic consequences, positive consequences on their fitness level.
So there you are. Step it up, skip the lift when you can. Now, just 4 more flights of stairs to go.
Yeah, the newly athletic James Bullen with that story. What I want to see is whether he actually does it tomorrow after the show. And you're listening to The Health Report here on RN, ABC News and CBC Radio across Canada. I'm Norman Swan. According to a new report from the Grattan Institute, 2 million Australians who need dental care avoid or delay going to the dentist because they can't afford it. The report calls on the federal government to commit to a universal dental care scheme, and it also suggests a way forward. Stephen Duckett, who co-wrote the report, is in our Melbourne studio. But before we go to him, let's hear comments on this story, which have already come in after an online article by Olivia Willis. Welcome, Liv.
Hi, Norman.
So what have people said in response? You've got to have over 150 responses, I think, to your piece.
Yeah, it's been massive. It's very much resonated with people. So I think people are feeling pretty frustrated. And the common experience is that there's, people paying pretty hefty out-of-pocket costs for dental because it isn't, in most cases, covered. So Christine says last week she went in for an extraction. She got it half out and the dentist told her they couldn't remove it without a general anaesthetic, that it would cost $2,500. She said, what if I can't pay that? And they said, you'll go on a waiting list for about 18 months. She's in agony with a tooth half out, so she just had to pay it on the day. And that experience is pretty common. Cody says he needs braces to fix his teeth, but he can't afford it. Again, was told he'd go on a waiting list. That would take, again, about 18 months. And it's not just people who are kind of relying on the public system that are finding problems. So even people with private health insurance, for example. So if he said she needed a root canal, it would cost $650.
That's cheaper, a root canal, actually.
Which is quite cheap.
But it's a lot of money.
Her private health insurance would cover $30 of that. So the experience seems to be people are pretty upset.
And where can people read your article, Olivia? After they've listened to the story?
That's right. They can jump on ABC News Online and find it in the health section.
Thanks, Olivia. Olivia Willis is the ABC Science Unit's health reporter. Stephen Duckett, welcome back to the Health Report.
Thanks, Norman.
I suppose you're not surprised by such comments?
Not at all. And you hear those stories all the time. And it's not surprising because more than half of the cost of dental care comes out of our own pockets. This is unlike prescriptions, GP specialists, where it's around 5-10%. And so you're inevitably going to have stories about people who can't afford it and the consequences of that.
Why is the mouth extracted from our healthcare system?
I think it's in the dim, distant past, Norman, that we need to look for the answer to that. So when Medicare was introduced, Medibank was developed in the late 1960s. Was obviously strongly opposed by doctors in the AMA, and the dentists too were not supportive. And so I think Gough Whitlam said, I'm not going to have too many fights. It's going to be hard enough to get Medibank and Medicare up. So let's just put dental aside for another day. And unfortunately, that other day never came.
And we've had things that have stopped and started, and there's now, I think for children and adolescents, and there's services obviously in the public sector from state and territory governments.
Oh, it's a complete mishmash and ramshackle arrangement. You never know. The schemes differ from state to state, and there are different exclusions and so on. And even if you're eligible in a state scheme, more than half the patients in state schemes wait for more than a year. And some of those stories Olivia reported to us just then.
And in the state scheme, the range of treatments is limited.
Absolutely, and the tragedy is if you have to wait for that year, something that your tooth might have, if you'd been there on time, your tooth might have been able to be saved, but a year later they take the tooth out.
Did you look at the knock-on effects?
Well, there's a huge amount of evidence, Norman, about the consequences of poor oral health. There's evidence about links to diabetes that go both ways. There's evidence about gut. There's evidence about cardiac. There's also evidence about employment, that people with poor oral health feel embarrassed about going to interviews and so on. And so there's lots of evidence about the consequences for people in addition to the pain that they might be suffering.
What would a national scheme cost?
We estimate that a national scheme would cost about $5.6 billion a year. This is a huge sum of money. We're not claiming that you could do this in one day. And what we're saying is you've got to say this is our goal and we want to get there over a 10-year period. I know it's hard.
But it is about the same as we spend on medical imaging. I mean, it's not...
It's not out of the question, and there's money to be saved in other parts of the health system and so on. So it's not an impossible goal. But but one of the problems, Norman, is in fact, even if you announced it tomorrow, you couldn't do it because we wouldn't have the workforce to do it. So we've got to actually plan it and announce this is where we want to go. This is a long-term vision for Australia.
So we're not overproducing dentists the way we're overproducing doctors.
So there's been a massive increase in the number of dentists, and many dentists are now working part-time. The rate of part-time working amongst dentists is higher than the rate of part-time working amongst doctors and physios, for example. And so there is some spare capacity in the dental workforce, and we need to have more oral health therapists as well to be working in this field. And so you could certainly expand immediately. We think you should expand immediately to cover pensioners and healthcare card holders, the low-income people. We think you can do that, and we've shown that you can actually do that with the workforce we've got. And
you should be said that in the public sector, dental therapists do a lot of the work that you're used to dentists doing in the private sector.
Absolutely, and we're suggesting that the scheme should be encouraging oral health practitioners, both dental practitioners and oral health therapists, working at their top scope of practice, because you don't want to have people who are well trained to do the preventive and the initial primary procedures not doing them and paying a dentist to do them when they don't need to.
So take me stepwise through, you say that this is going to take a decade if you actually started now. What would you do? What would be the stepwise approach?
Well, the first stage should be to say, well, first to say we're going to do it over a decade, but the first step would be pensioners and healthcare card holders. And what we're saying here is even then there should be a first step which says just expand it further in the public scheme to start with, because what we want to do is not have an open slather purely Medicare approach, but actually have a participating practice approach where dental practitioners would say, we're prepared to sign up to this scheme, and in exchange for signing up to this scheme, we're going to say there's going to be no out-of-pocket. So you'd immediately say there's no, if you're going to sign up, there's going to be no out-of-pockets. If you sign up, you say we're going to provide the data about what we're doing. So the funding agency, probably Medicare, would be able to compare the practices to see who's got a more preventive orientation, who's using evidence-based.
Do you think dentists will sign up to that?
Well,
we haven't had doctors signing up to that.
Well, this is a major expansion of the funding available, and I guarantee that the public schemes, the states would sign up to that. And I think
if the federal government's going to cough up, you mean?
Exactly. But and this would mean basically an end to public sector waiting lists. But I think there'll be private dentists who would sign up to that as well. Many private dentists are already signing up to the Child Dental Benefit Scheme, and we're suggesting the payment rates be roughly the same as the existing Child Dental Benefit Scheme. So we're confident that there'll be many dentists would be prepared to sign up to that scheme.
And the end point is what? An expansion of Medicare, a national health insurance scheme, or a separate dental health insurance scheme?
We're suggesting it should be what we're calling it is a universal dental scheme, because there are differences between Medicare and what we're proposing. We are proposing something based on participating practices. We are proposing a much greater monitoring, because we want to actually ensure that evidence-based practice is used. We want to ensure that we are using oral health therapists to the extent we can possibly use them. So it's not just a free-for-all, but a managed scheme which aims to actually, as efficiently as possible, expand dental care for all Australians.
So make up for, don't make the mistakes of Medicare around the second time around. Stephen, thank you very much for joining us.
Thanks, Norman.
Professor Stephen Duckett heads the health program at the Grattan Institute at the University of Melbourne. A leading Aboriginal researcher is calling for action in remote Australia to deal with a preventable epidemic of sexually transmissible infections, including syphilis, in a population that's actually no more sexually active than non-Indigenous people of the same age. Associate Professor James Ward heads Infectious Diseases Research, Aboriginal Health, at the South Australian Health and Medical Research Institute.
We've had endemic rates of sexually transmissible infections in remote Australia for over 2 decades now. Very common STIs, very easily diagnosed and very easily treated.
Such as?
Chlamydia, gonorrhea, trichomonas, and more recently an ongoing outbreak of infectious syphilis across the north of Australia. They mostly occur among young Aboriginal people living in remote communities. And unfortunately, we haven't had very much success in bringing these rates of STIs under control for a long time now, despite being easily tested for and treated.
And I understand in Northern Australia there have been babies born with congenital syphilis and at least one has died.
Yeah, unfortunately over the last 4 or 5 years there's been a widespread outbreak, and it keeps on moving into different areas across Northern Australia. We've lost 7 babies due to this syphilis outbreak, and that's very unfortunate given that we have available testing and treatment for syphilis in Australia. There's only 2 populations in Australia with syphilis predominantly, and they are men who have sex with men in the city and young heterosexual people in remote areas. Health literacy about syphilis and many of the other STIs is very low in these communities, and so people may not be aware that particularly women, may not be aware that they have to have ongoing testing and treatment at every checkup during pregnancy. And unfortunately, some of these women are missed, and then the babies end up passing during pregnancy or at pregnancy.
Is it just an issue for remote communities?
It's a particular issue for remote. Around 50% are under the age of 25. Lots of social determinants that drive these persistent rates of STIs, such as poor education and lower health literacy, shame and stigma, alcohol and other drugs potentially play into this, but also health service access and health service delivery. When young people do access health services, STI testing is less than optimal in most communities around Australia.
So what's the solution here?
The approach we've taken over a long period of time now is to trial single interventions, for instance, new point-of-care machines or continuous quality improvement in the health service, or we've tried to understand what young people are doing and what they know about STIs. We've trialled all these single interventions, and what we haven't really done now is bring all of these interventions together. But also there's some new technology and new biomedical interventions that we should be embracing, such as genomics and particularly metagenomics.
Why would that help with an enormous remote Australia public health problem?
The group in Melbourne have really been doing this with Melbourne population, particularly MSM, men who have sex with men in Victoria. And what they've identified is clusters of gonorrhea, for instance, the size of the cluster, and they've linked that with the identified patient data. They can see which groups are most at risk for gonorrhea, how big a cluster is, the same strain of gonorrhea, and how many occur in a single year. For us in remote, what we're often trying to find is the 10% of people who have an STI across large expansive areas in remote Australia. So if we can implement genomics into remote work, we'll be able to identify where clusters occur, how big the cluster is, and perhaps pinpoint our interventions to bring that under control much faster than the broad brush approach that we have to STIs now.
Now, presumably services have got to be young people friendly. I mean, this is a problem in non-Indigenous general practice. I don't know whether it's a problem in community-controlled health services.
Yeah, well, I don't think there's any difference between non-Indigenous and Aboriginal and Torres Strait Islander young people in terms of how they feel. They're generally feeling very well. STIs are largely asymptomatic. People don't know they have an STI. And so trying to promote testing is really a big focus of some of the work that we've been doing around improving health literacy, making sure that people present at a health service at least once a year, making sure they understand that they're in a high-risk age group for STIs in these communities. Of course, we've got to do lots of work around health services to make them more young and adolescent-friendly. One other thing that we've really been thinking about lately is the interconnectedness of sexual networks in remote communities. Small populations, small availability of sexual partners. There's a prevalence of 15% or so of gonorrhea or chlamydia in small communities. We've determined that sexual practices aren't that different between non-Indigenous young people in terms of the number of partners. What is really driving this prevalence, I think, is the interconnectedness of sexual networks across communities and within communities.
And James, what's the situation with HIV in remote communities?
What we're seeing now is more and more outbreaks in remote communities. For the first 25 years, we rarely saw HIV in remote areas. If this happens, we really have to mobilise a whole lot of resources. There's not a lot of HIV expertise in remote Australia. These high rates of STIs facilitate HIV much more easily, and we really need to keep a watching brief on HIV across remote Australia because these STIs potentiate HIV transmission if HIV does come into play.
And just to be clear, it facilitates HIV because there could be open wounds or
inflammation in genital area particularly.
So just finally, James Ward, if you could wave a magic wand, what would it look like?
I really advocate for a comprehensive approach to STI control in remote, and that would involve continuing to address the underlying determinants of STIs and poor health generally, which is education, housing, income. I would focus a lot of our efforts on health service delivery and making sure that we can test the right people at the right time and at the right frequency. I'd make sure that we're incorporating genomics, which is newly available and will become much more integrated into routine surveillance over the next 5 years or so. Make sure that we understand mobility and its impact on STI transmission. How do we overcome shame and stigma, particularly for young men who access health services about a third less than young women in these communities? What we need is a very comprehensive approach to STI control. And what we're about to embark on is trialling this in some regions over the next little while if we're successful with our research applications this year.
James, thank you very much indeed.
No worries, thank you.
James Ward is Associate Professor and Head of Infectious Diseases Research in Aboriginal Health at the South Australian Health and Medical Research Institute. According to a report from Mind Gardens, a Sydney-based neuroscience alliance, the economic cost of brain and nervous system disorders, mental health issues and substance abuse in Australia is $74 billion a year, and that's besides the human cost. One of the members of the alliance is the Black Dog Institute, whose chief scientist is Professor Helen Christensen. Helen is also joint CEO of Mind Gardens. Welcome back to the Health Report, Helen.
Thank you, Norman.
What conditions are we talking about here?
We're talking about substance abuse disorders. We're speaking about depression, anxiety, mental health disorders and neurological disorders. So any of the 20...
So multiple sclerosis, dementia, things like that.
That's right. Any of the 22 disorders that are used to describe that particular category in the World Health Organization analysis of the burden of disease were used.
Now, we've covered the burden of disease many times on the Health Report over many years. This is called the disability adjusted life years. This is years of life lost to disability or years of life lost because you die prematurely.
That's right.
And mental health has always been surprisingly near the top of that.
That's largely because of the prevalence of mental health disorders. So in Australia at the moment there might be 720,000 people who have depression. So it has a huge impact on the cost and burden of disease.
Now, why are you found that the burden is, so if you take the whole disease burden, total disease burden of everything in Australia, you found that 20% of it is mental health, what I've just described, the substance use and brain disorders. And it's 11% worldwide. Why are we double?
It's an interesting question because...
You got it wrong?
I know. I hope not. But I think it's because the burden of disease from other countries is often communicative diseases. So in Australia, our main problems are going to be brain disorders as we go forward because communicative diseases are being fixed.
So infectious disease, apart from the story we obviously had before, and the $74 billion, that's everything put in, hospital, loss of work and so on.
It's productivity and health costs.
So you talk about in your recommendations, what you get, what value for money, and that's an early concept in the burden of disease study, which is called best buys. What are the best buys to actually help this problem and for the best return on investment?
Yeah, so we did some analysis of particular interventions across these three groups of disorders that were likely to bring good return on investment. And there were some major interesting findings there in terms of, say, exercise therapy is highly effective for a number of neurological disorders. Internet CBT is effective for depression. These have...
Which is a special interest of yours.
Yes, but it's something that I think that we haven't really been able to put into practice, even though it's highly effective.
Why not?
Well, I think this is where we look to what are the major things that we have to do within the organisations that we have that are delivering healthcare. So ICBT, for example, can be found on the internet, but it's not actually...
So this is cognitive behavioural therapy.
Yeah, that's right. And it's not integrated into our health systems. It's not delivered preventatively. There are no incentives for industry to get involved. Whereas in the UK, for example, they introduced a measure very early in the 2000s that people should be allowed or offered this sort of intervention in every trust in the UK.
And we're talking, in fact, we're talking paradoxically about the young and the old. It's a bit hollowed out in the middle, but by and large, we're talking about mental health disorders starting in adolescence and some of these other problems such as dementia happening later in life.
That's right. It's an interesting graph that you see, isn't it? It's all about early, for mental health disorders and substance abuse, it's about young people. For dementia and neurological disorders, it's primarily about people older.
Now, Mind Gardens is an alliance of a hospital service, research institutes and so on, coming together on this with different interests. Is there a new model of care that you've got an idea for here?
We do have a model of care which is loosely based on the idea of the cancer comprehensive centres. Essentially, in the past, we've siloed services. We haven't looked at prevention. We haven't brought people together in a one-stop shop, even though we know there's a huge amount of comorbidity. So one of the components that we're trying to think about is the Apex Clinic, where people are concurrently looked at from every side, if you like, to determine what are the causes for their particular problem at that time. And then we're delivering a number of specialised services once they've been looked at from every angle.
So have you trying that yet, or that's still on the drawing board?
Oh, thank you. Yeah, we have a number of these smaller clinics starting, but the actual... and we,
Where does the money come from? And what's the incentive?
Well, I think the incentive is that these four organisations really want to do something. It's quite palpable in the board meetings and so on. And this is a bit different because it's four organisations that have come together in a company structure in order to make inroads on this. So everybody's serious about it. And the contribution so far has been some in kind, some salaries and so on.
But where will the money come from for these holistic clinics?
Well, I think there's a number of opportunities that we can work through, and we're looking at potential government funding. We're looking at philanthropy because, amazingly, in our area, philanthropy is one of the biggest contributors to improving our mental health and drug and alcohol services.
So watch this space.
Yeah, watch this space.
Thank you very much. Helen Christensen, who is Chief Scientist at the Black Dog Institute and Joint CEO, or Interim CEO, I should say, of Mind Gardens in New South Wales. I'm Norman Swan. This has been The Health Report. See you next week.
You've been listening to an ABC podcast.